Hi there, my name's Emma Woodmansey, and today I'm going to be talking to you about electrical stimulation therapy and negative pressure and some preclinical work that we've been doing to understand the mode of action of each and how they work in terms of wound healing. This was work that was done in conjunction with Dr. Rodman Martin and Seeker Biomedical. Before I jump into the results of the preclinical work that we've researched, I just wanted to give you a bit of an introduction and a background around electrical stimulation therapy and why bioelectricity is really important and sometimes overlooked within wound healing. Generally, the normal intact skin acts as a battery, and we have a charge potential between the outside of the skin and the inside of the skin. But that changes when you have a wound, as you can see in the top diagram. You then have a current of injury from the intact skin across that gap, the defect that you have in the wound, which allows cells and the wound healing processes to actually take place and guides that process and stimulates lots of different processes, which we can talk about in the next slide. In chronic wounds, that process of current of injury is diminished. We know that in diabetic patients and also in elderly patients, the current of injury is less, which obviously can have an impact on wound healing. But we can replace it. We can replace it with electrical stimulation therapy, and that's what we're hoping to talk about today. As I mentioned, bioelectricity and electrical stimulation as an adjunct can therefore have an impact on many different processes within wound healing. It can change the way that cells behave, it changes their gene expression, which therefore changes the protein synthesis, and then changes in physical behaviour in terms of proliferation, cell migration, cell differentiation, for example, fibroblasts to myofibroblasts, and also polarization for that migration, so it guides them in terms of where the cells need to migrate to, which again is really important in terms of wound healing. And you can see here that there's many different processes that bioelectricity is involved in terms of migration and proliferation, and also the later stages of remodeling as well within wound healing. So it's critical across all phases, really. From an evidence perspective, obviously evidence-based wound care is extremely important in anything that we're using for wound interventions. Electrical stimulation therapy has a really high level of evidence supporting its use in wound healing for stimulating wound healing. You can see here more than 30 RCTs, and from that we have over 5 meta-analyses and 6 systematic reviews, which are the highest levels of evidence that you can have, which is supporting wound healing with electrical stimulation therapy. Accel Heal is a microcurrent electrical stimulation therapy, and that also has high levels of evidence. You can see here 2 RCTs supporting the use of Accel Heal in wound healing. One which was a VLU study, randomized controlled placebo trial, and this compared Accel Heal with a sham product which looks like the same but doesn't deliver the electrical stimulation therapy. And you can see from the results here, there was a much faster rate of healing with the Accel Heal product compared to the placebo. So 3.6 weeks faster healing with Accel Heal, in fact. In addition, there's a second RCT, and this is a healthy volunteer study using 12 healthy males, where again, electrical stimulation therapy with Accel Heal was compared with a sham, so a product that didn't deliver the electrical stimulation therapy, on each side of the buttock of these healthy volunteers. After 48 hours of treatment, those healthy volunteers were sampled and a tissue biopsy taken, and the gene expression of the cells within that tissue biopsy was analysed, and it also showed a reduction in gene expression of cells that were linked to inflammation, which again we understand might have a role in what we see clinically with the pain reduction that we see when we use Accel Heal. So we've talked about adjunctive therapies and active therapies, and it's really important clinically to understand when we use adjunctive therapies and how we use them. And we need to really understand how they work to be able to understand where they fit within our clinical pathway. Obviously, when we're treating a wound and we're giving it the best standard of care and it's not on that healing trajectory, it's time to think about using an adjunct or an active treatment. So we think normally around 2 to 4 weeks of standard care, and if the wound's not progressing, we can then progress to an active treatment. So for example, things like negative pressure or electrical stimulation therapy that help to optimise that really good standard of care. Once we see that wound progressing and we see that wound on a healing trajectory, we can then step down to standard of care again. As I mentioned, it's important when we're thinking about building pathways, building clinical pathways and toolkits within our clinical practice, that we should understand how things work so that we can optimise where and when we use them. For example, recent evidence has highlighted that negative pressure wound therapy stimulates wound healing by mainly reepithelialisation, which is an interesting result. And in addition to that, there's also been some preclinical work highlighting that negative pressure combined with electrical stimulation therapy can also lead to an increase in fibroblast transformation and also an increase in a thing called alpha smooth muscle actin, which is linked to wound contraction. So really interesting to understand that from a preclinical perspective and then also think about how that fits into a clinical pathway. But we also wanted to then raise the question as, well, actually, how does electrical stimulation therapy compare to negative pressure, which is the basis of this work? Briefly, it was a comparative study and we had 3 different groups in a porcine preclinical model. The animals had a full thickness wound and the Axel heel or the negative pressure was applied to those wounds. So we had group 1, which had electrical stimulation therapy alone, group 2, which had single use negative pressure alone, and then group 3 had both therapies together. Within that 12-day treatment period, you can see we looked at wound healing visually using image analysis. And also at day 12, we looked at histology of the tissue after that treatment and looked at various measures of wound healing in different ways. Looking at the image analysis, we see that electrical stimulation therapy alone and negative pressure alone had very similar healing rates, as you can see over the 12 days here. Negative pressure had a slightly faster healing rate in the first 3 days. And then we start to see the wounds that had electrical stimulation therapy much faster in the kind of end of the period, so day 6 to day 12. So really important to kind of highlight that. And also the combination of therapies had very similar healing as well. So the wound area reduction that we see with those wounds was very similar across all 3 groups. We then decided to look a little bit more detail in terms of was this by reepithelialisation as per previous work, or was it through contraction? And you can see here this graph on the right-hand side highlighting the proportion of wound healing by contraction or by reepithelialisation. Axel heel EST on its own had a much higher proportion of wound healing by contraction in comparison to negative pressure, which had a greater proportion of wound healing by reepithelialisation. So obviously combining the two, you can see here as well, it optimises both angles of wound healing, which is great. And again, really fits with the clinical kind of application of this in terms of understanding the mode of action. We can then understand which piece actually fits in that jigsaw. So the benefits of both technology were maximised basically when we used them in combination. And this is just a little bit more detailed in terms of the histology, but it does concur with the data we just talked about in terms of a higher reepithelialisation rate with PICA, but a higher contraction as shown by alpha smooth muscle actin with Axel heel. And when you combine the two, you get the optimal benefits of both technologies. So what does this mean in practice? So Axel heel, microcurrent EST, supported the wound healing to a similar extent as negative pressure, as you see, but also the benefits of both of those technologies can be used together in those optimised clinical pathways to show complementary action, really. We know that there's many barriers to healing, and clinicians, when they're thinking about treating those chronic non-healing wounds, really need to address each of those barriers for that wound to progress. And to be able to do that, you need to understand all of the products in the toolkit, all the interventions and how they work and what the mode of action does. to be able to optimise that treatment in the best way. We also need to then incorporate that into guidance to be able to understand when and where to use different products to their maximum benefit, really, in terms of pain management and also in terms of treatment. Really need to kind of think about these active technologies to really shift that needle in progress for that wound and to try and move the needle to heal that wound. I think from this work and from the clinical data that's already out there from an evidence perspective, we can see that electrical stimulation therapy really should be considered as a really critical part of those pathways to shift the needle on healing chronic wounds.